Good afternoon, everyone. My name is Dan Messina. I am the President and CEO. So I want to welcome everyone joining us today. We have a regular program of Lunch and Learns, and I'm very, very excited to introduce Dr. Kaimov in a minute. So just to give you a little bit of a sense of what's happening out there. And by the way, let me also say before I forget, one of our long-term nurses from many moons ago, and was actually the Nurse of the Year, Kathleen Bavaro, who happens to be sitting here in the blue, getting ready to sit down. Kathleen, welcome. We'd love to see our former staff come and join us. So lots of things are happening at the hospital. You'll see lots of new faces kind of building on the great foundation that we have. We've been always known for that family atmosphere and for really providing good community-based care. We're now, continuing to rebuild. As time goes on, we always have to rebuild. And I'm really pleased with many of the new faces that are joining the hospital staff. Certainly Dr. Kaimov, who I'm going to turn the microphone over, comes to us from his training at Lenox Hill, and is a fellowship-trained joint surgeon. We're really excited about his joining the team. We have several other new faces joining the team. Dr. Christopher Lisi, who is our new chief of ENT. We have a new bariatric surgeon, Dr. Barkin, who comes to us from Long Island. And really a whole new team of people just continuing to build on the great foundation of care that we've had in the past. Someone else I should also mention from Harvard Medical School, the chief of neurosurgery in Columbia. He has come on board, Dr. Cohen, Doug Cohen, and he brings to us a whole nother level of clinical capability here, not just in general brain work, but also in complex spine work. So there are great things happening here. I know many people feel sometimes you have to go into Manhattan. That thought is really changing very rapidly because the Dr. Kaimovs of the world and the rest of the team really have provided some exceptional opportunities for Staten Islanders here at Rumsey. We're in the middle of building our new emergency room, and that is about an 18-month project. That is a major project, $100+ million project. That'll have a second story that will be the future home of our peri-op and surgical department, which will be replacing all of our operating rooms and renovating and expanding the entire surgical footprint. So I'll definitely be giving Dr. Kaimov some great new surgical support as he continues to build the program here. Also, part of that equation is critical care. So lots of things happening. New parking lot. I'm sure that's near and dear to your hearts. If you parked, or if you took a taxi, you wouldn't understand what I was talking about. But soon we'll be adding about 240 new parking spots to the campus, and we all can't wait for that. Last but not least is a cogeneration plant. So we will be replacing our electrical infrastructure with a cogeneration plant. That basically is 2 gas turbines that will allow us to come off the grid and actually produce our own electric, certainly save a great deal of dollars on our utility bills, enhance the load, offload some from the existing grid and help our community, which is also an important facet. But more importantly, when we have these major electrical damages and we have those big storms, we will be kind of producing our own electric and will not have those disruptions. So lots of good things happening. So I'm really pleased to kind of turn the podium over to Dr. Kaimov, just a great person, clinically terrific, and we'll really be talking to you today about advancements in joint replacement. Certainly somebody who used to be a runner, a marathon runner. My knees are like scrambled eggs right now. So I hope I don't have to see you too soon. I'm hobbling around a little bit, but I know that I have a great resource in Dr. Kaimov. So thank you again, and Dr. Kaimov.
All right, thank you for that introduction. Again, I'm Mikhail Kaimov. I'm really actually very excited to be here today to talk to you about something I'm quite passionate about. So we'll get into it. Just a quick background on me. I did my undergrad training at NYU. I did my medical schooling out on Long Island at NYIT and my residency out on Long Island as well. And then I came over to Lenox Hill to do my joint replacement fellowship. And actually, I'm very lucky that two of my mentors were actually trained by the basically godfather of knee replacements, who developed the first widely adopted knee replacement. So I come from that background. I have a lot of slides. Most importantly, I want to make sure that whoever has questions gets them answered. So feel free to stop me at any point. I'll make sure we have time at the end to address any concerns. But if something sparks your interest and you have a question, just raise your hand. I'm happy to stop and address them. Alrighty, so we'll get into it. So why are we even talking about any of this, right? So osteoarthritis is one of the most common things that we see in the office, whether it be hip, knee, which is my specialty, elbow, wrist, really any joint. The prevalence is on the rise, and it's only going to continue to rise. And part of the reason is people are getting older. And the baby boomers are now starting to come of age where, they're starting to need these procedures. One of the other things, unfortunately, that's contributing to the increased numbers is obesity, still on the rise. And I'll show you some interesting graphs about how that's contributing to orthopedic visits and joint replacements specifically. So again, one of the most commonly performed and successful surgeries. There's been tons of articles recently in the last few years published about how not only from a financial perspective, specifically hip replacement surgeries are very successful, but also from a patient outcome perspective. It's one of the best surgeries that you can get. No bias. And no financial disclosures either. No one's paying me to put up any of these pictures. So these are just some interesting numbers out of Mayo Clinic. And these are actually already 10 years old at this point, from 2010, just showing you exactly how much of an impact these surgeries are having. So 2.5 million hip replacements and 4.7 million total knees. It's quite an interesting figure, and we can see.
Excuse me,
Yes.
could anyone tone some of the lights down in the
Yeah,
kitchen?
I don't want to
Can't
turn them
see it
all.
that good.
Yeah, no problem. I don't want to turn them all the way off. There you go.
Yeah, that's better.
Alright, so these figures here, you can see that, the population between 60 and 80, that's kind of where the majority of, traditionally, the population where we've been doing hip replacements, knee replacements. This is also changing. We'll get into that a little bit more. So this is a graph from the CDC, just showing you, again, it's a better visual representation. This is pretty much where we're at, between that 60 and 80 group. And it's a lot, 2.5 and 4.7 million. So, and this is actually going to be on the rise. This is also outdated figures. What's happening now is this end of the graph is starting to come up. And one of the things I could talk about is obesity. Obesity is on the rise. So that's this next figure that I have. So the prevalence of obesity over the years, this goes from 98 to 2011. And you can see it's a steady climb. That people who are obese are now getting more and more joint replacements. The bad news is obesity is one of the risk factors for many a complication in joint replacement. The good news is we're getting better at doing it and decreasing the risk. So a lot of the risks are modifiable. We're better at making smaller incisions, which means less risk of infection. We're better at controlling diabetes, better at controlling heart disease. These are the things that come along with being obese. Most of the time, the studies that are published say, well, if you're obese, you're at increased risk. And they kind of leave it at that. The reality is, if you're obese, you most likely have other factors that are contributing to your increased risk. So we're getting better at managing those. So as these numbers continue to climb, and I don't see a reason why they wouldn't, unfortunately, we have to keep up, and we've been getting better at doing that. So kind of going back in time, pays homage to the original trailblazers that kind of are the reason why I'm here today. So the first kind of joint replacements that we have on the books date back all the way to the 1800s. They were terrible, they did terrible, they didn't have cement fixation at the time, so they all kind of fell apart. In the 1920s was where things started to pick up. Smith-Peterson originally developed a glass hemisphere that they would just put on top of the olive ball. That did terrible because it's glass and it fell apart. They quickly replaced that with metal, and that did okay, but they didn't have cement. So in 1958, Sir John Charnley in the UK, who's credited with the modern hip replacement, developed a Teflon cup. Teflon doesn't have very great biomechanical properties, so that was quickly replaced by polyethylene, which is the precursor to what we're using now. So it's a plastic, right? So shortly thereafter, the original total knee was developed. It was a dual patellar, then followed by a dual condylar, but it wasn't until John Insull in the 70s developed the first condylar total knee, and this is the gentleman that trained my mentors. So like I said, very lucky to have that knowledge passed down. So let's get into some of the talking points for today. These are just some historical pictures. This is one of the first charmly hips implanted, so you can see the design has really not changed up to this day. I don't have any pictures of the new ones, but that's pretty much what they look like. With the difference is we've changed the geometry of the stem to get better fixation in the hip so they last longer. We've changed the type of plastic, which I'll talk about, and now we put a metal cup where that plastic sits. And I'll talk about the materials. And this is one of the first two generations of those Insull-Bernstein knees. Pretty much kind of look the same, but we've made small adjustments. So we've come a long way, but not really. So these are in no particular order the things I'm going to talk about. Longevity, right? So how long is this thing going to last me? That's the number one question people ask me in the office. And I want to talk about that first. Accuracy, how well are we putting these in, right? So if we're putting them in well, then we're relying on the properties of the materials we're using for the longevity. So that helps us answer that first question. Cost factors into every single one of these points. Implants are expensive, they're expensive to produce, they're expensive to our society, but like I said, from a financial standpoint, it actually is worth it. So we'll touch on each and every one of these. So longevity, right? So it boils down to the materials. Assuming we put it in right, without any, difficulty, no complications, it boils down to that piece of plastic in between, the two metal pieces in the knee and the two metal pieces in the hip. So the piece of plastic, polyethylene, originally when it was developed, was just high density polyethylene. Now we're getting better. We're doping them with vitamin E. They're highly cross-linked. So the data that you may see and that we quote to our patients is the data that is from the original high density polyethylenes. It's the 30-year data now where 85 to 90% of these are still in patients and they're doing fine. The hope is that the wear rates on the stuff we're using now, which is this highly cross-linked polyethylene, is better. And that's what it seems to be. So this is a study by Stryker. I'm not paid by anybody, but they have a nice graphical representation to show you. So this is their original polyethylene. And what this is measuring is in total hips, how much wear per year in millimeters. So really, and this is their most modern second generation high cross-linked. The wear per year is reduced dramatically. So the hope is, the data we're getting is on this stuff now, this is much, much better. So in theory, these things should last over 30 years, assuming no other issues. So that's really exciting. This is just another graph to show you the penetration of the cup over time. So this is the old school stuff, this is new. And this is over a 7-year period. So you can see it kind of levels off, whereas the old one kept wearing out. So we're getting better. I mentioned vitamin E doping. So what that does is it actually impregnates the polyethylene with vitamin E, which is an antioxidant. And one of the things that contributes to the degradation of the plastic is oxygen, unfortunately. So the vitamin E seems to also be helping, but that's very, very, very new to our practice within the last 10 years. But the data's still not out there. A lot of this is lab data. All right, so accuracy. How well are we putting these things in, right? Because I said if we put it in well, then it really boils down to the metal and plastic. So we'll talk about traditional instrumentation, and then I'll get into some of the stuff that I kind of like because I grew up in the age of computers and robots, navigation, robotic assisted surgeries, things like that. And really, does it all matter? And there are lots of people that will argue both sides. So conventional instruments. So I wanted drawings because I didn't want people to get grossed out. So traditionally, and this is how we still do it, this is how we make our cut for the shin bone, for the tibia. You have an extramedullary guide, and I don't want to say we eyeball it because that's going to make people nervous, but realistically what you're trying to do is you're trying to have this rod align with your shin bone, and then you can dial in however much angulation you want through the jig, and then we make the cut, right? So that could leave some room for error. Unfortunately, it does, but fortunately, we're all pretty good at making the cut at the right angle and the right distance. So, and similarly for the thigh bone, you know, you have to insert a rod up the femur to then make the cut. So we're relying on mechanical instruments to do that. And I'm a little biased because I said I grew up in the age of robots. But this is still how we do it. This is how I do it. This is how I was trained to do it. But I was also trained on robotics and computer navigation. And my mentors could do this with these instruments with their eyes closed. And they did it well 100% of the time, every time. Unfortunately, the data says that even experienced surgeons can still sometimes screw this up. And I don't want to scare anybody, but the good news is it doesn't seem to make that much of a difference. And that's what the argument is against robotics, and I'll get into that. So navigation, what computer navigation is you use a bunch of sensors to map out the anatomy of the patient. And then what it'll do is the computer, by using mathematical algorithms, will tell you where to make those cuts, okay, as opposed to using the jig. So it'll tell you where to place the jigs and dial in exactly how many degrees you want. So it's kind of cool. It looks kind of like this. You know, this is one of the systems that you can use. It's an onboard, basically, iPad type of thing that you can use to early in the operating room, dial in what you want, and it'll map out the anatomy of the knee or the hip intraoperatively. Now, the argument that's made against this is, well, who cares? We know that experienced surgeons who do a lot of these can do it with manual instruments, no problem. Remember, we have to put a big rod up the femur, up the thigh bone to get our alignment, and then we also have to properly align that jig on the shin bone. So my argument to them is, what do you do with this? This patient has had surgery previously. Their shin bone is completely bent, it's not straight, and they have a huge deformity here. So getting a rod up any of these femurs is going to be virtually impossible. So that's the argument I make for navigation. That's exactly what was done here. This is not my case, this is from a scholarly journal. But you can see they were able to put a total knee in using navigation, and the alignment afterwards is perfect, right? And so the argument I make is there's no way you could have done this without it, because you can't do an intramedullary guide on this, which is putting the rod up the femur. So I think there's a time and a place, and certainly there are papers to show you that. So this is showing you variability between manual instruments, which is hand-guided, which is the shorter of the two graphs in both. And so this is the placement of the shin bone and the thigh bone component in the total knee. And the taller graph is always the navigated one. Again, small study, but it's promising. So really, the interesting thing about this paper was even experienced surgeons sometimes screwed it up. But like I said, the counter argument is, who cares if it's within a couple of degrees? It seems to make no difference. So a lot of the older studies, or studies that are new, that are pulling from old patients, show that even a 3-degree variability really makes no difference. So that's been kind of the big argument against it. So I'm just trying to show you both sides of the argument here. I do believe in the navigation. I think for cases like this, it's tremendous to make sure that you're doing it right. All right, so we'll get on to robotics. Well, with robotics, what it is there's one big company that's been out there forever, Stryker Mako. There are other companies that have come along that do the same thing, but differently. In a nutshell, what it does is you can pre-plan your surgical cuts, everything from the position of your implants to how much bone you're going to cut. And what it does is it won't let you deviate from that plan unless you need to. In the OR, you can say, well, you know what, it didn't account for this, I need to change it. You can do that on the fly. But in a nutshell, what it doesn't let you deviate. And I'll show you a picture. But really, the unicompartmental knee replacement, so the partial knee replacements, which I'm sure you guys have heard about, that's where most of the data is available. And that's where the strongest argument for robotics stands today. And that kind of makes sense, because if you're only going to replace part of the knee, you want to make sure you do it well enough that the rest of the knee doesn't go on to degenerate more quickly than it would have. Because if you put in a uni, which is a partial knee replacement, and the rest of the knee now goes on to develop arthritis, you got to take that uni out and replace it, do a total knee. So that data is very compelling, and I've been to conferences where people are yelling at each other about it. I certainly think it makes a lot of sense that for a partial knee, if you can have a robotic guided surgery that lets you put it in just right, I think the outcomes are greatly improved. In a total knee and a total hip, the data is still not very convincing. Certainly people do it. So this is kind of what it looks like. This is the Stryker Mako. So it uses these optical trackers. This is the robotic arm itself. I don't know who that is, I just pulled this picture. And these are pins that are put into the leg, and these are captured by a camera that's on this side of the field to basically control where this robotic arm goes. So if you deviate from your cut, it turns off. It doesn't let you do it. So it's pretty cool stuff, and this is what the preoperative plan looks like. So you get imaging beforehand, CT or MRI, depending on the system. And some of them actually, you don't need any imaging. They let you plan it on the fly in the OR based on certain points in the patient. It'll actually map out their knee. So this is the plan. It won't let you deviate unless you manually override it. Pretty interesting, I think. So what are the studies saying? So it's interesting. So WOMAC is a measure, it's a survey that a patient can take, and it basically has them grade their functional and pain scores. In this one, the lower the number, the better. It's a little counterintuitive, but basically at 6 months, statistically significant differences in having less pain in people that had robotic arm-assisted total knees, approaching statistical significance with physical function, and a total score statistically significantly better than manual. You know, it's one study. The thing with orthopedic literature is that for every one of these, there's one or two saying the exact opposite. So it's kind of anecdotal and patient and surgeon preference. I certainly have done enough of these in training that I think it can make a difference in the right hands. The scary part is people who don't do a lot of these think the robot can do it for them, and it can't. So, you know, I have a lot of patients who think the robot does the surgery, they don't want it. It's not, we still do the surgery. The robot is a tool, and I think the tool, you have to use it carefully, right? And in the wrong hands, the tool can still do harm, I believe. All right, so blood loss. From a patient perspective, where are we at? So when I was in residency training, a lot of our knee and hip replacements used to get blood transfusions postoperatively, and it kind of bothered me. So this is an elective procedure, you come, you know, you choose to get this done. Why is this happening? So this has actually changed an enormous amount. It used to be not that long ago that patients who were booked for total knee or hip replacements would donate 2 units of their own blood preoperatively, and then would get that blood back after the surgery. That's long gone. Nobody does that anymore. And for a good reason, we don't need to. So one of the things that has come around that's been used in cardiac surgery for decades is tranexamic acid. Basically, in a nutshell, it reduces the amount of bleeding in the OR. This has, and there's been multiple studies on this now, reduced the need for blood transfusions, reduce intraoperative blood loss, to the point where there are people doing these surgeries in surgery centers as outpatients. So it's been a huge, huge development. So the postoperative transfusions for the most part have gone away, which will tie into a few of the next points that I'm going to talk about is how long people are staying in the hospital now. And it's much, much less than it used to be. So other things that we have kind of gotten better about is we have access to bipolar sealers, which are special cautery devices that we can use in the OR for mostly for total hips, which again reduces your intraoperative blood loss. That only came to market, I'm trying to think, probably within the last 7 years, widely used. Tourniquets, kind of also a debated topic in knee replacement, whether or not you should use it, whether or not you need to use it. You know, one of the advantages is if you're cementing, which most of us do still, the implants in, it allows for better penetration of the cement. The cement that we use is it's not adhesive, it's more like a grout. So you need to make sure it penetrates into the bone. That seems to be the best argument for using a tourniquet. But we actually my partner and I did a total knee without a tourniquet the other day. Well, great. You know, and there's a lot of debate as to whether or not it causes some post-operative pain because, you know, it goes around the thigh, it squeezes the quad a little bit. So post-operatively, is there more pain? Is it from the tourniquet? Maybe. We don't really know, because tourniquets have been around forever and ever, and we've been using them pretty routinely. The one thing we've been great at doing is we've gotten rid of drains. So it used to be pretty much routine that if you had a total knee, total hip, you would come out with a little suction drain that would suck all the blood that was still pooling in there out, so that you didn't get a huge blood collection in the joint. Gone. Not even recommended by the academy anymore that you leave them in. Because A, it was a potential source of infection, and B, you can't get tamponade in the joint if you keep bleeding into it. And now the blood loss that we have is so much less than it used to be that we've gotten rid of drains completely. Alright, so this is what I'm talking about. So when I was in training, lots of people were getting blood transfusions. Now, and this continues to dip, it's so much less. And me personally, like I said, seeing these patients come in for elective cases and having to get blood transfusions made me a little uneasy. I'm a lot happier with it now. And like I said, I think that the stuff we're doing in the OR is helping a great deal with that. So the next thing I want to talk about is length of stay. How long are people staying in the hospital? This is a little outdated again. This is CDC data, but they only have it until 2010. Downward trend, if we were to do kind of a line down the middle. Overall, it's downward trend. Obviously, the younger people were staying less than the older people. It kind of makes sense. This is approaching 3. I'll tell you that now it's even less. There are people who are going home same day, next day. Of course, there are still people who need to go to rehab, and they'll stay for 3 days in the hospital and make sure that they're doing well enough to be discharged safely. But this is going down, and that's great too. So this is the discharge destination. So like I was saying, 2000 compared to 2010, also pulled from the CDC. This is the number of people by age and by sex who are going home. All the bars on this side are much taller. So we're getting better at doing stuff in the OR so that people can get out of here sooner. And not only get out of here sooner, but also some of them are able to go home. Now, I always tell my patients there's no place like home. So this brings me to outpatient joints. Like I had mentioned, there are people doing them in surgery centers. I believe it's the future. I think you have to be very careful in the patient selection. There are guidelines that are out there. They're not from any specific agency or anything of that nature. It's more from academic standpoint, what sorts of patients would fit well into this criteria. Certainly, geographically, it could be dependent. There are certainly pools of high-risk populations that wouldn't fit into this category at all. But there have been some arguments to sending patients home or doing outpatient joints. The counter-arguments have been, it seems that patients do just as well, they seem to be happier, and they seem to do better sooner. They get back to their daily activities, they don't feel like they're in a facility, they just get up and go. One of the arguments is this theoretical risk of readmission. You go home right away, well, what if you have too much pain, or what if you're bleeding, or any amount of things. And that's been refuted in a few good studies, that the risk isn't increased. It's equal to if someone had stayed in the hospital and needed to get care versus if they had left that same day. And the few reasons that people can't go home sometimes is they get nauseous, they haven't gotten enough fluids post-operatively, that they get dizzy, so then they end up having to stay. But really nothing serious, at least from the papers. So one of the ways we have been facilitating this is these rapid rehab protocols that we initiate with our anesthesia team, our physical therapists. So when we have these rapid recovery protocols, physical therapy gets you up 3 to 5 hours after the surgery, gets you up and moving, gives you some confidence that, hey, this thing is not going to break on me. Because that's really what a lot of patients think. Oh my God, they just put this thing in me. If I get up and do anything, I'm going to make it work, I'm going to break it. You won't. You can literally, as soon as you can wiggle your toes, you can walk on it. So as we get better at having enough resources to get physical therapists to the bedside, getting patients up, we'll be faster at getting patients out. Because when you're convinced that you can get up and move, you want to leave. So a couple of the parameters that we use is, if you can ambulate 100 feet and you can do a flight of stairs, you can go home. And they use that even if you end up getting admitted. If the next day you're doing well, me personally, I would have no qualms with you leaving. And then immediately upon arriving home, the home physical therapist, visiting nurse, checks on the incision, checks on your progress, making sure that you're moving the joint, that you're not getting stiff. And then you pretty quickly, within the first 2 weeks after that, transition into outpatient physical therapy at an office. And the recovery for hips tends to be a little bit quicker than for knees. I'm not quite sure why. The demand on the hip is different than the demands on the knee. So hip patients tend to be a little bit happier. They're both happy, but the hip, they tend to notice it less than the knees. Pain control. One of the other things that we're getting really good at is, you can get general anesthesia or spinal. The spinals used to last forever, and you used to get a Foley catheter, but you couldn't urinate. Now we have short-acting spinals. They're only a couple of hours. They wear off pretty quickly. By the time we're done with the surgery, the spinal's wearing off. With general, when you wake up, you can move. With the spinal, though, you have to wait. Now that's really not an issue anymore. Like I said, when we're done, the spinal's pretty much worn off. So you felt nothing during the surgery, but you can move everything. Peripheral nerve blocks have been huge for us. So the anesthesiologist can selectively block the nerves distally by the knee, or even in the hip. They can sometimes do a block in the musculature of the back to decrease your pain. And that gives people the confidence to get up. And that's important, because like I said, biomechanically, those joints are stable, they're rock solid. We just need to convince the patients that they can get up and move, and if they have pain, they won't. So that's been really huge. And something else that I have a lot of experience with is these periarticular injections. So injecting the knee or the hip during the surgery itself. So for generations and decades, there have been different cocktails that different surgeons have implemented. I personally think one of the biggest developments has been Expro. Not every surgeon uses it. My mentors have done studies on this, where it's a liposomal bupivacaine. So to make that simple, it's bound, so it's not all released. So when you go to the dentist and they give you the injection, it's all released right away. Once it wears off, it's done. This is bound, so it actually gets released over the course of a few days. And this is off their website, the proper injection technique. You want to make sure that you infiltrate the tissues deep, all the way to superficial, and in multiple areas. And this stuff, there's papers that say it doesn't do anything, but I've seen in patients, and in my own personal experience, there are people that have no pain. It's really quite amazing. So, you inject it all the way in the back of the knee before you put the implants in, and it releases over the course of 3 days. So this, paired with the blocks, really gives patients the confidence to get up and get moving. This is a study that they published that, opioids and the opioid crisis are huge now, so everyone's kind of using that as their measuring stick. So their published data is 78% fewer opioids, opioid consumption in patients after total knees, and 14% less pain if they were grading their pain scores, from 0 to 10. I think that's pretty impressive. And I've seen this stuff work. I know there's lots of papers that refute it and lots of facilities that don't use it. But I personally think it does work. And there are actually some facilities where the anesthesiologists use this in the nerve blocks. That the nerve block lasts for 3 days as opposed to a day. And one last thing that I'll talk about is how we're putting the implants in now. We've gotten better at that too. So on the knee side, incisions used to be huge because the instruments were ginormous. We've gotten to smaller incisions, so that means less blood loss, less muscle damage, because the instruments have now come a long way, even the conventional instruments, where we can use smaller incisions. And the implants have become lower profile, that way we can sneak them in there without having to make a massive incision. One of the things I did want to talk about is the anterior approach for the hip. So the traditional, most commonly used approach is through the buttock to do a hip replacement, which is all fine and well, done well, they do great. But a new option that has become very popular over the last few years is the anterior approach. It's a muscle sparing approach, so you don't have to cut any of the muscles. And what this seems to do for us, from the patient perspective, is in the first few weeks, they have less pain. And like I keep harping on, when they have less pain, they want to get up. So they seem to do a little better in the first couple of months. ultimately, far out, if you map them out, compare them to the other approaches, they seem to do about the same. You know, so is there really a difference? I think so, because again, if you have the confidence that you can get up and move, I think ultimately you'll do better. You know, the data is a little tricky on that, but my preference is to do it anteriorly in the right patient. You can't really do it on everyone. So what I like about it is you're doing it under extra visualization, so you can see where the components are going in. So you see your cuff placement, you see exactly how much bone you're taking. There's no dislocation precautions afterwards. You don't have to worry about them dislocating. Now, we've gotten really good at doing it traditionally through the buttock, where most of us don't use precautions anyway. So that part of the argument's kind of going away. But I still think it's an important mental safety issue for the patients, where you can tell them you don't have to worry about it popping out. Now, of course, there's a theoretical risk of it popping out, but it seems to be less, and that's what the papers certainly show. But muscle sparing, less pain, I think to me personally, that makes a difference. But again, a well-done posterior is a well-done posterior, and they do equally well. So I'm going to wrap it up there. If anyone has any questions, I'm happy to address them. Yes?
You go through in the thigh now as opposed to the buttocks?
Well, we do both. So I was trained on the anterior approach, which is here on the front of the thigh, but I also do the posterior approach, which is through the buttock. Yeah. So both options are available.
Yeah, I've seen both because my wife has one on the beach.
And what did she think?
Well, she was psychologically convinced by a friend of hers that not going through the buttocks was better. She claims it's better, but I don't know. It looks to me like she's taking longer with the therapy.
So, yeah. So everyone's different. So, but like I said, you know, having a friend convince you is different. And so a good posterior is a good posterior. And you know, there are surgeons who swear by the posterior approach. I'm just happy to offer both options to my patients, and certainly there are certain patients that I would counsel against doing an anterior. And there are certain patients that I would advise to do the anterior versus the posterior, simply because of lifestyle or body habitus or, you know, other comorbidities. But both options are available.
Okay.
I think there was a question in the back. Yeah.
Yeah, in the back, for your knee replacement, sometimes the patient, you know, complain of, or tells you that there's like a clicking.
Mm-hmm.
What do you
So,
suggest to tell them?
well, clicking can be from a couple of things, right? So it's metal and plastic, right? So there's moving parts in there. Clicking could just be the kneecap hitting the thigh bone as it's gliding over. Some of us choose not to put a piece of plastic on the kneecap. I do in 95% of my cases. So that kind of clicking is okay. The other type of clicking that can happen is if they have instability, and that can be problematic because, you know, the plastics come in different sizes, and you kind of have to make sure that you put the right size plastic in there. Or what can happen over time, and is more common, is the ligaments get stretched out, and then the knee becomes loose. So that clicking they're feeling is actually the plastic hitting the thigh bone in an awkward fashion. So if it's that needs to be addressed, likely surgically. But painless clicking usually is the kneecap.
So as long as they're not complaining of pain, that's okay.
Well, you know, it should still be brought to the surgeon's attention, just to make sure, but a lot of the time it can just be normal. Sometimes the patients become hyper aware. You know, most of our joints click, and as long as they don't bother us, we don't pay, like my knee just clicked, I don't pay attention to it. But once somebody has surgery, they become very hyper aware of that body part, and they focus on every little thing, and that can be just that sometimes. But 1 in 4 patients will have some anterior knee pain after a knee replacement, whether or not the kneecap is done. And unfortunately, that's something that we don't really have a good answer for.
How long have you been doing these surgeries?
So I've been out of fellowship for 2 years now.
2 years?
Yeah.
And No, approximately, I don't know, I don't say weekly, monthly, how
Mhm.
many surgeries do
So
you
my
do?
partner and I both do hip and knee replacements, so on a weekly basis, we'll probably do, let's see, about 6 a week between the two of us, and we do them together.
Oh, you work with partner?
Yeah.
What percentage of your patients
Mhm.
rehab at a rehab center
Mhm.
or at home, and what do you recommend to them?
Well, so I'm new to this community, so I'm still trying to figure out what works here. My training was always tell everyone they're going to go home because that was kind of the new avant-garde thing to do when I was training. I certainly think there's a time and a place for rehab, and we were just discussing this earlier. It seems that it's a cultural thing. So, I trained on Long Island, everyone used to go to rehab, and every patient that would come in would say, well, Aunt Betty went to rehab, I want to go to rehab. And it took a few years to change that mentality. And I think certainly that's something new to the island, based on my observations in the last few months. So for the time being, the majority are still going to rehab. The select few are going home in about a day or two with very close follow-up to make sure that they're getting the outpatient therapy that they need.
You suggest that at home you have less risk of infection?
Certainly if you're not in a facility around other people who are sick, I think just logically the conclusion is that yes. But I also think it's a comfort level. People are more comfortable at home as long as their pain is controlled.
Now, can they do stairs right after you have the hip done? Like,
Yeah, I mean, again, it all comes down to pain control. So
yeah.
with the posterior, it tends to hurt a little bit more because you have to cut through the buttock muscles and you have to split them. So you feel that a little bit for the first few weeks. But certainly mechanically, the muscles should all work, and they do. It's just dealing with the pain, making sure the pain is adequately controlled, and that patients aren't too doped up where they can't get out of bed because they're dizzy. But yeah, certainly they can.
I had unusual, I had a hip replacement, and I had also, many years before, I lost all of my shoulder, and I had to do an HC separation.
Okay.
I went to therapy, but only, rehab rather, but only long enough I could wipe my own butt, and then I went home.
Okay.
That I think is a consideration to some people.
Right, of course.
I really didn't have the heart to put that on my wife.
Right. So you have to be able to do activities of daily living. Take care of yourself, groom yourself. It has to be safe, but you also have to be able to function. If you're just going to sit home and lay there, it's obviously counterproductive to what we've done. We do the easy part, I tell patients. We get in there, we replace the joint. The hard part's on you. You have to stay motivated. You have to make sure you do the rehab and that you can actually get back to functioning. Because the last thing you want is for it to function as bad or even worse than before the surgery. Anybody else? No? All right, thank you so much, guys.
Yeah.
Pleasure. Thank you.
Thank you.
Thank you. Thank you. Good information. Thank you.
Mayo Clinic.